So step 3 is, the first one, obviously, define tumor, place your probes. Third one is actually confirm you got the ablation. So that's the meat and potatoes of it. So I usually do a tract ablation for my cases, take my probes all the way out if I'm in plane. But sometimes if I'm doing like a really steep out of plane, I had to come from really low to get up to a dome lesion, you can actually kind of keep some of your probe in the liver and it won't distort your ablation confirmation software too much, or not your software, but your images. So I'll either take the probe all the way out or get it out of my field of view.
Okay.
So I can have a clean CT of my tumor bed. And then I'll do another scan, and that's arterial, venous, pre-arterial and venous. You're looking for bleeding arterial, very rare. But in the venous phase, that's when you're going to upload that to AC. So you go back to step 3, which is bring that scan over, and you drag it over, and now the computer is going to merge those two. So it's going to take your scan and the pre-scan and merge them. So what you do right before that is you just define your ablation zone. It has a really cool feature. It's called a create tool. So it kind of uses Hounsfield units and a little computer algorithm to figure out what your ablation zone is. And it's very accurate. Where it's not perfect, and sometimes if you have like multiple probes or redirects and it's not a great shape, you can just kind of use one of those ROI functions to carve it a little bit. But I don't know, perfect is the enemy of good here. I want to have a nice ablation zone, but I don't want to add 20 minutes to my case either. So the create function does a really good job just kind of giving you what you need. And then you ask the computer to fuse it, and that's the magic of it. It fuses those two, and then you get a scan overlaying your segmented tumor with your margin and your ablation zone. So you get to see, did I get it? Did I get my tumor? Did I get my ablation zone? And did I get my margin? And that's it. I mean, you can then know for sure that you got what you came to get. And if you're not, then you can kind of make a mark there and use that to target and kind of do a reablation. But most of the time, having used it for a while, I had pretty good results of getting it the first time. But if not, I go back in, no problem. Yeah.
So that was my question. So if you have something, say you left over a little bit of tumor on the inferior margin, things are distorted now, like the ablation zone's kind of contracted, but you can use the ablation confirmation software to say, okay, this is where like the bottom part of the lesion is, or like, do you then use the ablation confirmation software to get back at that spot, or do you just kind of use the CT landmarks that you already have like kind of formed from the ablation zone?
So this version of AC, you don't use them to target.
Okay.
But what I do is I'll go to the same slice, be like, okay, at this slice, which you can correlate over to your, image acquisition machine, whatever it is, and say, okay, the lesion was here. This is where I left margin. Okay, and I put an ROI at that spot on that slice, and I go back in.
Okay.
So that's something that's different. But if you were a family member getting ablation and you knew you still had margin left, you'd obviously want them to go back in. They're already in procedure. They already made the trip there. They're already getting it on the table. It's like a surgeon doing a procedure, checking the margin with pathology, be like, oh, there's a little bit, like a couple cells here. I think we'll be okay. We'll keep an eye on it. No, you go back in and you clean that part out. And I think that's an established thing to do in surgery. And it's not really an IR. It's kind of just quick, get done. But I think the times where you do have to go back in, it's worth it. You just don't have the recurrences. You're able to prove that you got what you came to get for and have that kind of A0 ablation, right? That get everything the first time kind of approach.